So now for the main event. So Dr. Miller has been on our board of advisory for a long time. He's been coming to this Smart Life Forum, Silicon Valley Health Institute for about 15 years now. He has become a leader and pioneer in anti-aging and longevity medicine. So if you don't want to get old, talk to Dr. Miller. He is currently a charter member of the American Academy for Anti-Aging Medicine and has passed the first ever board exams in anti-aging medicine in December 1997 and December 1998, qualifying him board qualified by the ABAEM Board, American Board of Anti-Aging Medicine. Dr. Miller is the founder and CEO of California Age Management Institute. He just started a new software company with details to be announced soon. He is on our advisory board, as I mentioned. He will be talking this evening about the real issues in heart disease. Please give a warm welcome to Dr. Miller.
Thank you. We almost had a problem in terms of the connection, and I always worry about, are we going to have a good connection or not? And it kind of reminds me, calm down, calm down. I'm always amazed when I see these broadcast studios or radio stations that have got gazillions of dollars worth of equipment. They said, oh, we've got some technical difficulties. I don't know how that happens, but I think we've overcome it. And so I think we've got some clear sailing here. I want to thank everybody for inviting me back again. I sort of feel like when the host comes on Saturday Night Live and says, you know, I'm up to number 5, I'm up to number 6, I'm up to like the number 1. And I think I've been here at least 5, 6, maybe 7 times in the last 15 years, so I always enjoy coming back. It's a great crowd. And what I have for you tonight is a really long lecture. It sort of violates some of my rules, which is never put more than 90 slides or more than an hour, because you're all going to fall asleep. But this is fast-paced, and there's more information here than you've ever seen before in terms of what are the attributes, the causes, and the etiology of cardiovascular disease. And so we're going to cover the whole spectrum. So what Christine Green gave you is like one area and one approach, and virtually everything she said is a sort of a segue to what we're going to discuss now in terms of what are the multiple etiologies of cardiovascular disease. It's not just one cause. It's not cholesterol. I never believed the cholesterol theory when I was in medical school, and they all called me an idiot. Because everybody knows that. But I also remember even when I was a kid, when I was a teenager, the craze was, you got to all eat margarine because that's really good stuff for you. And I always thought, that stuff is junk. I mean, even then I knew this. Intuitively, this stuff is really junk. So let's start out. This is just around the corner from here. Anybody know where this is? Nobody knows, okay. This is a Rastorello Preserve. This is where I go to clear my head out. Spend hours and hours. This is what I call the New Medicine series for you. It's everything you want to know about cardiovascular disease and probably more. So let's dive in. So let's look at heart as a metaphor, in terms of philosophical, just the metaphor. What is heart? Follow your heart. He died of a broken heart. An honest heart possesses the kingdom. The heart is wiser than the intellect. The only lasting beauty of the heart. This spans the ages, spans philosophical concepts, that the heart was the center of the soul. So, in 1511, Leonardo da Vinci, contrary to what the popes wanted and what the religion wanted, started doing dissections along with Michelangelo and others, and started looking at the physiology and the structure of the heart apart from what the ancients had believed about the heart. Incidentally, the ancients thought the head was just a cooler. So Sir William Harvey was really important because what Sir William Harvey was one of the first anatomists to actually show that the heart was a vessel that pumped blood around the system. And he was one of the first to actually show scientifically, through some very elegant experiments, that the heart wasn't just this organ that was a metaphor, but actually had some physiologic function pumping blood around the rest of the body. This was pretty radical in those days. So we look at the anatomy of the heart, and we're going to go through this in detail, but basically, is my marker working? No, it's not working. Sort of goes on and off. Anyway, we're going to go through this in more detail. Here's the action of the heart. You can see how the heart pumps into each segment there, goes to the lungs, gets oxygenated, comes back from the lungs, goes into the left ventricle, and gets pushed out the aorta into the body. Comes into the heart, gets oxygenated, once it comes back into the left ventricle, goes in the aorta, goes in your brain, goes to the rest of your body. And that's the basic physiology. Great, thanks. There we go. What was that? Okay. So this is the way that I ideally would like to work up a heart. And again, what Christine Green had said, we're just seeing more and more of this not being done in medicine because you only have 15 minutes. We don't care about etiology. This costs money. Everything's being reduced to cost effectiveness. How much does this cost? As opposed to, can we look at the heart from various modalities? So what we look at is we can look at the heart electrical. The heart is an electrical organ. That's what an EKG does, looks at the electrical output of the heart. You can look at the vascular, so you can look at angiography, which is just basically looking at the pipes. You can look at wall thickness with carotid ultrasound, which is what we're doing, carotid intimal medial thickness. You can look at calcium scoring, which you look at the calcification in the arteries. You can look at arterial stiffness, which is pulse wave analysis. And we'll show that, what these are. Different ways of looking at cardiac function. We can look at biochemical monitoring, which is sort of my love because of my biochemical background. All the lipids, the HDL, the LDL, cholesterol, and the triglycerides. Structure, we can look at the echocardiogram. So we look at the structure of the heart. We look at the valves, which is totally overlooked by most cardiologists until it becomes almost too late. And again, the aortic valve is the one I see most often. We look at perfusion, which is dual isotope heart scan. Hardly anybody's getting that, which is the metabolic function of the heart. And finally, we look at energy, which is VO2 max. How well are you oxygenating your system? So you look at this, and now that you get a much more richer picture of what is your heart. It's not a chest x-ray. It's not an EKG. It's looking at all these different modalities because every one of these is important. Electrical, vascular, biochemical, structural, perfusion, energy. So let's look at some functional cardiology. Cardiology, vascular disease, and this is what we were told, starts as an inflammatory process. So we look at hormonal, we look at nitric oxide, we look at arginine, endothelial relaxation factor, endothelin. In fact, it turns out the heart has its own built-in hormonal system that hardly anybody's really studying because we're only looking at it as sort of this, again, this Newtonian mechanical device as opposed to this rich plexus of vagal influence and all these internal hormones that are going on. Vascular, looking at flow and rheology, and I'm really big on rheology, which is just flow characteristics. Is your blood thin? Is it thick? What are the blood vessels? Are the red blood cells? Are they ready to aggregate? Do you have anything that's thinning your blood out? We look at mechanical, the valves, electrical, and biochemistry. So these are some aging fundamentals. What is it that happens as we get older? Well, as we get older, we're rusting, we're oxidizing, we're getting stiffer. So we look at inflammation, which is burning up, and again, this is the segue. Cardiovascular disease starts as an inflammatory process. And even in medical school, I remember being taught first there was an injury and then everything else happens. So you look at glycation. Glycation is what makes us stiffer. Glycation is basically high fructose corn syrup, too much sugars, thickens your arteries, thickens your lens, thickens your muscles, makes you stiff. And finally, energy. And this is an interesting thing. I'm not going to go into this in depth because I could spend about an hour talking about this. In the 19th century, there was this debate in science about what is energy. So Newton just told us what power was, which is a much easier concept to get across because it's a mechanical concept. Energy is, frankly, is much, much more difficult. You have to take a course in thermodynamics to discover Helmholtz and Gibbs free energy. And even when I had Chem 5 at Berkeley, I never mastered this course. So it's probably easier to think of as we're getting older, we're not so much losing energy, which is a difficult concept, as much as we're losing power. Locomotive power, vocal power, sexual power, energic power, political power, whatever it is, we're losing power as we get older. One of the things that I'm telling all my patients now as they get older, don't stop moving. Keep moving. So that's power. So let's look at an integrative model. An integrative model would be looking at rheologic, which is shear stress, viscosity, elasticity, the calcium paradox, vitamin D, vitamin K, mitochondria. And none of you are taking enough vitamin K.
I am.
How much are you taking?
90 milligrams of MK4 and about
90.
400 of the
Okay, so you're 90 milligrams. 90 milligrams, okay. Because the dose that I recommend is 15 milligrams. That's 15,000 micrograms. Hardly anybody's getting that. So let's start at the top here. Rheologic stress, viscosity, elasticity, calcium, vitamin D, vitamin K, mitochondria. We've gone way beyond cholesterol already, haven't we? Okay? So let's look at vascular health. I spend a lot of time talking about this. A man is as old as his arteries. Thomas Sydenham, 1624. 1624. In many ways, a lot of the concepts I'm going to introduce you to, we've known about this stuff for 400 years. We're sort of rediscovering inflammation. We're rediscovering arterial health as a marker of overall health. So these are the major coronary arteries here. So this is the right coronary artery. This is the left coronary artery. So here's the left main. That's really important. Here's the left, here's the left main. Here's the left anterior descending. And I always forget, I think this is the circumflex right here. So this is the left part of your heart that's really important. This is where most heart attacks occur. But this is just important. The right part of the heart supplies the lungs. It's driving the lungs. And the left side here is what goes to your brain and the rest of your body. So the left side is really important. But the right side is just as important. This is the critical thing that's missed by most cardiologists, most physiologists, is that when you look at this, that is looking at the heart from a plumber standpoint. Look at those. So if you have a blockage right here, that's called a widowmaker. Because if the eye gets blocked off, everything distal of that dies. But the reality is the heart has this rich plexus of microvasculature where in many instances it kind of bypasses all these. So you look at cardiologists, and we'll see how the cardiologist looks at an angiogram, but you have this ability to bypass these blockages with this rich microvasculature that's never visualized. You don't see this on an angiogram. You don't see this in any modality that we're doing. I think this is probably just an anatomical model. I don't know any living way that you can see this rich microvascularity. So the common concept is, here's a normal artery. Here's the endothelium and the media. And eventually what happens is it gets kind of junked up, and it gets junked up in the outside. That's sort of the old concept. Too much fat, too much sugar, builds a bunch of junk builds up, and it gets plugged up. That's not how it works. So if you look at it, see there it is. It looks at from this diagram that it's just arteries are just getting plugged up. Too much pig fat, too much bratwurst, too much bacon, too much green fried tomatoes. If anybody grew down south, you'd know what I'm talking about. So the reality is you look at the intima and you look at the media, which is the muscular. What happens is there's an injury to the media intima and everything starts invading this thing here. So this is the correct view here. And I thought that maybe one of the problems is what they call right here. This is probably the basement membrane. We know there's a basement membrane in the kidneys. If the basement membrane in the kidneys gets violated, you got a lot of problems with kidney disease. I don't know anybody who's talking about the basement membrane here, which is is the border between the intima, which is the inner lining, and the media, which is the muscular layer there. Something happens here. Once that layer gets violated, that's when you got problems. So what happens is, normal artery here, stuff happens, and it starts invading this here, and all these cells start invading here. So here's that vessel, here's where it's become thickened, right here. So let's go, we're going to come back to this in a little bit. Let's talk about what I talk about a lot, lipids. Cholesterol, irrelevant. I have to tell my patients this every visit. Your total cholesterol is irrelevant. When you tell me your total cholesterol is 240, I don't care. I have lots of women who see me who have total cholesterols of 240 and they're healthy, totally healthy. Why? Because they have a high HDL. So total cholesterol is the combination of your HDL, your LDL, and your VLDL. So if you're one of these women, because guys don't have this, if you're one of these women who have the HDL of 140, you're going to have a really high total cholesterol. Total cholesterol, meaningless. So you want to look at triglycerides, the one factor that's totally overlooked. So probably when I was a medical student, mainly what we were looking at was total cholesterol. And then we were starting to look at, well, maybe we ought to look at LDL and HDL, but mainly it was a focus on total cholesterol. Then we got a little bit more sophisticated and said, well, maybe we should look at some subfractions. We ought to look at the LDL and the HDL. HDL, everybody talks about the HDL as the good cholesterol, and the LDL is the bad cholesterol, as if the HDL has little smiley faces, and the LDL has little frowny faces on it. These are not cholesterols. And it actually took me years to figure out LDL is a carrier protein, and it carries cholesterol to the heart for reasons that it's trying to repair an inflammatory injury to the heart. The LDL carries cholesterol to the heart. If you get, this is big point number one. LDL carries cholesterol to the heart. HDL is like a little vacuum cleaner. HDL carries cholesterol away from the heart. So why high HDL theoretically is this thing that's clearing your heart of all the excess cholesterol. So that's why you want lots of HDL. Women always have much higher levels of HDL. And over the years, I've pretty much assumed it's estrogen related. That you have more estrogen, more HDL. Then we started looking at VLDL. VLDL is related to triglycerides, related to carbohydrates, it's related to sugar. So then we started looking at risk ratios. We looked at the total cholesterol, the HDL, the one that's probably the least informational to me. I look at the LDL, the HDL. That's a little bit more important. But frankly, I'm looking more and more at the triglyceride, the HDL. That is a diabetic risk factor. Carbohydrates, feed triglycerides, higher triglycerides is the one that's overlooked. VAP, now we get a little bit more sophisticated. So in the last 5 or 10 years, we got the VAP. And the VAP is an acronym, forget what it stands for, but it was a quick method of looking at some of these more sophisticated risk factors. And now the latest one in the last 3 or 4 years is Liposcience has kind of done their little marketing shtick. And now what we're looking at is total particle numbers. So first it was cholesterol, then it was LDL and HDL, then we were looking at more sophisticated like the ratio, then we looked at the VAP and we looked at particle size, now we're looking at particle numbers. It's always an effort to look at what is the one thing that's causing the problem. But cholesterol doesn't cause heart disease. And triglyceride to me is the one that's overlooked more and more. So how many remember Tim Russert? Okay. Tim Russert died suddenly at the age of 58 with a totally normal cholesterol. It was 150. He had triglycerides that were off the chart. Incidentally, he also led a very stressful lifestyle, probably went to Europe, drank a lot, ate a lot, rushed back home. Stuff happened. He had high triglycerides, normal cholesterol. So what else do we have here? So in the last 15 years, you know, one of my mentors was talking about cholesterol, was talking about what we call pattern B. This is a different concept. This is Robert Saperko. And so Saperko is the one who was trying to bring this concept into our consciousness, which is maybe if you have these big LDL, fluffy LDL particles, big LDL particles, that they just kind of float on by. And if you have these small little LDL particles, dense, small LDL particles, they have a much greater likelihood of invading into the intima and the media and causing this inflammatory process that causes cardiovascular disease. So this was kind of a big advance when we looked at pattern A, pattern B. Pattern A, big fluffy LDL particles. Pattern B, small LDL particles. But the big advance really was that pattern B is almost always high triglycerides, low HDL. And really, I still think it's more of a triglyceride problem than it is a cholesterol problem. So what are some of the predictive risk factors that I look at? I measure this on just about every patient every time. And this is not happening. You go to Kaiser, you're not getting any of this. You go to your doctor, you're not getting any of this because it's now all, how much does it cost? What's insurance going to pay? My insurance does cover this. Do I have to call for pre-authorization? Forget it. I'll just order 4 tests and be done with it. That's what's happening to all of you today. That's what's going on in medicine. So I look at fibrinogen. Fibrinogen is an acute phase reactant. It increases your tendency to clot, thickens the blood, more likelihood that you're going to clot, forming a heart attack and stroke. You go into hospital with a heart attack, the first thing to look for is your fibrinogen. Because your fibrinogen is elevated, they give you TPA, big shot of that, and say, hey, we just cured you. How about if we look at your fibrinogen before you go into the hospital? So I look at fibrinogen in everybody. Lp(a) is a marker that people have sort of kind of put on the wayside. It causes, or it may accelerate atherogenesis, thickening of the heart, more hardening of the arteries. And this is one that was studied by Mary Malloy at UC San Francisco 15 years ago, and it's never gotten a lot of press. And the interesting thing is, with the Lp(a), women can have higher Lp(a)s, and it's not as harmful. Again, I think it's estrogen protective. Men can have Lp(a)s that are elevated. Most of you are not having this measured. My thinking is that Lp(a) is more harmful for men as a cerebrovascular problem more than a cardiovascular problem. Because I think it's more of a problem in your 60s and 70s and 80s. And saying 70 used to sound real old to me. Doesn't sound as old anymore. Old is 20 years older than you. So when you're 10, 30 is old. When you're 30, 50 is old. When you're 50, 70 years old, okay? And when you're 70, well, 90 is old, okay? And when you're 90, I'm not sure what is old, Harvey. 110, okay? Okay. CRP, we talked about CRP. So CRP is just another measure. So you see, these are inflammatory measures. And the LPPLA2, I use this also as an inflammatory marker because the LDL, when the LPPLA2 is elevated, it means the LDL is now becoming more inflammatory. Mast cells are coming in, histiocytes are coming in, that whole inflammatory cascade that I'm going to show you. So these are predictive risk factors. I look at these, okay? But I say predictive in a sense. So let's look at this. Now let's see if this works. I'm going to keep my fingers crossed. Let's see if it works.
You skipped homocysteine. You say something about homocysteine.
See, it's not going to work. It never works. Okay.
Talking about audio or?
The audio. It's not working. So homocysteine is an amino acid that's poorly metabolized as we age. It does require the MTFHR gene, but it turns out the MTFHR gene, that mutation is actually really common. So I've almost stopped testing for it because it's so common. But homocysteine gets metabolized to methionine. Methionine is really important for DNA synthesis. So methylation is a really important process for DNA synthesis. So if you don't have that enzyme that converts homocysteine into methionine, and the homocysteine builds up, it's a big irritant. So as homocysteine rises, that's found to be a really high risk factor. Same as gout. Gout is when your when the uric acid, there's a gene, it's called xanthine oxidase, uric acid gets converted to urea. Urea is soluble and you pee it out. So if you don't have that xanthine oxidase, uric acid builds up, you get gout. So that's what all these enzymes are for.
Try the video one more time, Phil.
Let's try it one more time. I don't think it's going to work because it should be bigger than this. So I have 3 videos on here, and they've never worked. And it's really too bad, because this is really a cute video. So someday you guys will be able to see this video. It's a really good video.
Upload it to YouTube and point to it.
So we'll march ahead, okay? So here's some new risk factors. Here's the ones you've never heard about. And this is really interesting to me because a lot of these have to do with physics. And the only course that I did terrible on when I was in college was physics, because I made the mistake in my freshman year of physics. I took physics 4A, which was for all the engineers, and they were talking about Newtonian mechanics, and I couldn't get it. So I switched to physics 2B, and I got A's without even going to the class. So I've always come back to physics. It's like, maybe I could finally get this as I get older. Mechanical stress is a big deal. Viscosity is a big deal. Loss of elasticity and calcium shifts. So let's talk about this. Again, I told you about these LDL particles. So here's a large, fluffy LDL particle. Here's a small LDL particle. Apparently these, and you see how complex it is? It's a carrier protein with a lot of cholesterol in it. And here's this is a smaller one here. Actually, I'm sorry. So this is HDL. So the carrier protein that's carrying cholesterol away from the heart. Here's the LDL particle that's carrying cholesterol to the heart. Now, why do I say about Tim Russert it wasn't about cholesterol? Because the Framingham study, which is probably the best study that we've had, a little community outside of Boston, where they actually studied the entire population. They've been doing this for at least 40 years. So we have a really good ongoing cross-sectional population study, probably the best study outside of, I think, Iceland, where they're studying the entire country. That would never happen in this country. And what you see is the difference between those who had a heart attack and those who didn't have a heart attack, there was no difference in their cholesterol. None. And what you conclude from this is cholesterol is a bad predictor of heart disease. And it goes back to what Christine said, and I could talk about this for a long time, difference between association, causation. Causation was talked about endlessly by Aristotle, had 4 postulates of causation, and then it was discussed by David Hume, who was a great Scottish philosopher. So this idea of causation has gone on for a long time. What is causation? Cholesterol does not cause heart disease. You can see it's a bad predictor. So what do we do that we go beyond some of these biochemical markers? You've got to do imaging. And this is what I'm really big on, is imaging. So I've seen some people come to me at 39 years old, and their LDL is 250. Their total cholesterol is 400. They're worried. I do imaging on, arteries are clean as a whistle. Cholesterol doesn't cause heart disease. So you look at imaging. So it's originally what we were doing 15 years ago, and I was one of the first doing this, and this was kind of far out, nobody was doing this, and then suddenly, I think maybe about 10, 12 years ago, Mayo started doing it. Once Mayo started doing it, it was okay. So, huh?
The bandwagon.
Well, now it's on the bandwagon. So, and they would do it in the ER. If you had a chest pain, you had a normal super fast CT scan, then you were cleared. So what it does is electron beam was originally the Imatron, which then GE bought out. So now it's the GE Imatron. So there's actually 2 types of scanners. And a lot of hospitals, what they'll do is they'll use their normal scanner, which is a spiral CT scan, and they'll kind of readapt it to your heart. But it's not the way it works. The right one is to do the electron beam, the EBCT, and that one is specifically dedicated to doing scanning for your heart. And it's really quick, it's really fast, it only takes about 4 or 5 minutes, and that's the one that shows you calcification of your heart. So this is an imaging study to say, here's your numbers, here's the risk factors, here's what happened to your mom, here's what happened to your father. What's actually happening to you? What's going on to you? Now we've come from population-based studies to individuals. What's going on with each one of you? That's what you want to know. You really don't care about 5 million other people who've been studied. You want to know what's going to happen to me, or what's going to happen to my husband, or my wife, or my mom, or to my dad. So this was the GE Imatron. Again, it started out as I think it was the Omnitron, and then GE bought it out. And that's what it shows. You can see there's a little bit of calcification here and a little calcification here. I always find these a little hard to read because they're cross-sectional. But that's what they do, is they calcify, they quantify these calcium scores. Here again, then they can do it in color so you can get a better idea of exactly where the calcium is. Now you're looking for calcium. Calcium is the end point of a buildup of inflammation in the body trying to react to that, wall it off, calcification. It's the end stage. But calcification alone still doesn't necessarily mean you're going to have bad stuff. It just means your arteries are not clean as a whistle. So furthermore, this is what we're doing in my office, and I'm one of the only people in the Bay Area who can do really quality CIMT scanning. And the CIMT scanning is what we're doing is we're looking at, again, this thickening here of from here to here, where it's thickened here. This is a chart that was given to me by one of my my consultants, showing that there is a correlation between the CIMT and cardiac events. And then it becomes kind of a controversy. I really like to look at the CIMT. This is what we see in the office. So we look at the traditional risk factors. So we look at your LDL, your HDL, triglycerides, we look at your blood pressure, we look at family history, and we look at diabetes. And we look at what are the traditional risk factors here. Then we scan up and down. Right here, that is the common carotid. Then we look at the internal carotid and the external carotid. Internal carotid goes into your brain, external carotid goes into your face. So what happens is the common carotid bifurcates. What I'm going to show you is, first of all, what I'm looking at is the thickness right here. The thicker it gets, that means there's more inflammation, more infiltration, and at a certain point there's a fibrous cap here. Fibrous cap pops open, blood pops out, stroke or heart attack. So what I want to know is, what's your thickness here? Because if you're down right here, that's supposed to be good. So in this case here, this person here actually did have some plaque, okay? So you see this plaque right here, and you see right where it is, it's right at the bifurcation, okay? And this is really interesting, because most of what we're seeing is at the bifurcation. And I'm going to show you why this is really interesting. It's a flow characteristic. This is not necessarily cholesterol. This is flow characteristic. It's a physical characteristic, because I'm going to show you there's more eddy currents. So this person here did have pretty significant blockage there. Not necessarily catastrophic. It's still probably about 50%, but probably needs further evaluation. So this person here didn't have any risk factors, nothing. So we looked at right here, this score right here was really low. This score here was really low, so their intimal medial thickness was really low. It was really low here. This person here was really cool, and I think this one had an LDL, just the LDL alone was about 160. So again, the LDL was really high, clean as a whistle. I told you I had one patient, his LDL is about 250 or 300. Cholesterol goes to 400 if he's not treated. All the drugs don't do anything other than it's going to wreck his health. And he has clean as a whistle arteries. I like this modality. There's about an 88% correlation between this and the heart. So now you could put this together with the heart scan and think you're now up to about 95% certainty what's going on with your carotid arteries, what's going on with your coronary arteries. So let's look at some other. This is the traditional. This is what happens when you go to your cardiologist. Cardiologist says, okay, let's do an angiogram. And there's a couple of reasons why he's doing an angiogram. One, because it's been validated. Two, because, to be honest with you, it's the only way you survive as a cardiologist. You don't survive as a cardiologist doing what I'm doing, talking to people, talking about the lipids, talking about their risk factors. There's no money in it. The only place you can make money as a cardiologist is doing the angiography and then putting in stents. So what does the angiography show? So this one did come out. So you can see here's a beating heart, and you can see right here this calcification. There's some stenoses right here. And the question is, what do? Are you going to stent that? Yeah, probably go ahead and stent that. Well, I mean, I'll just put a few stents in there. So this is the angiography. What you do is you snake up through here, you kind of go retrograde, go back into the heart, you come back out, and you look at each one of the coronary arteries. You're looking for calcification, you're looking for stenosis, you're looking for blockages. But this is really interesting. You know, Eugene Brownwald, you know, I think you'd never really totally realize how great some of your professors were until you're like maybe 20, 30 years out of school and you're really, in retrospect. Eugene Brownwald was our chief of medicine, scared the hell out of everybody, was a very imposing, almost arrogant figure, but in retrospect, probably was one of the most important cardiologists in American history. The people say Dudley White was the most important one. I think Eugene Brownwald was. Eugene Brownwald was chief of medicine, was chief of cardiology, was brilliant in terms of cardiology, and his wife was chief of thoracic surgery. So here you got his wife, who was chief of thoracic surgery, who was doing the original bypasses, and you have Eugene Brownwald, chief of cardiology. Can you imagine what that was like at the dinner table? So in 1977, Brownwald said an increasing number of patients are being operated on not because of the presence of intractable angina, but because of the hope, largely without objective supporting evidence at present, that the coronary artery bypass surgery prolongs life or diminishes the frequency of heart attack. This rapidly growing enterprise is developing a momentum and a constituency of its own, and as time passes, it will progressively be more and more difficult and costly to curtail it materially if the results are carefully designed studies of its efficacy prove this step to be necessary. In other words, what he was saying is what Eisenhower said in 1958, beware of the military-industrial complex. What Brownwald was saying was beware of the medical-industrial complex. And I still think in 1977, these words still ring true. Very prescient. So let's look at this. This comes from Circulation, 1996. Plaques occupy space, yet as pathology studies have shown in the past, the arterial lumen is not necessarily compromised. Remember what I showed you about that rich vasculature? Implying that the angiogram would be a poor tool to assess atherosclerosis in living subjects, however good it may be at detecting high-grade stenoses that cause symptoms. Here we got angiography. What's the value of it? So limitation of angiography increasingly has become apparent that the amount of narrowing of the coronary arteries is only of minor importance. This is really kind of a mind-blowing concept that nobody pays attention, nobody gives any credence to. But where does this come from? Okay? This came from Non-Invasive Heart Center San Diego, which is from Brownwald's chief center. So look at some other modalities. Echocardiograms. I'm really big on echocardiograms. I love echocardiograms. Shows the structure of the heart. The left ventricle, it shows the atrium, shows your ejection fraction. Ejection fraction is how much blood you can squeeze out in any one stroke. It's like the efficiency. It's like in a big cylinder, like a big Norton 750. How much can you squeeze out in one compression? So if you look at the echocardiogram, it's the ejection fraction, what I'm looking at. I want to see, optimally, I want to see it above 65. 50 is considered optimal or acceptable, but if you're at 50%, that's not too good. If you're at 30% or less, that's a pretty ominous sign. And I've gotten guys from 30 back up to 40 and 50, so it can be reversed, but it's a tough go. I use a lot of CoQ10, I use testosterone, I use other modalities. But this is generally a bad sign when it's 30. Efficiency of the heart, echocardiogram. The interesting thing is this is always estimated. There's not a definite number, and there's different ways of estimating. Cardiologists kind of gloss over it. It's the primary thing I'm looking for. Other imaging studies, sustemia, technetium, thallium, dual isotope heart scans. This is a way of looking at the metabolic flow. So I just showed you structural, I showed you biochemical. Now we're looking at metabolic, which is, are there certain segments of the heart that are not beating correctly? Are there dead segments of the heart? So this will show you here a normal one and an abnormal one. So this doesn't look good here. So, but the point of the dual isotope scan, which I can't hardly get any longer, is that dual phase seems to show and image the heart better than just one, which is either thallium or the technetium. And I'm seeing either thallium or technetium, but you need to do the dual to get a much better imaging study. Again, metabolic shows you the structure of the muscles. Do you have dead muscle? Okay? So let's look at the physics of the aging heart. Look at classic pathology. This is what we studied when I first started as a medical student. I never could understand it, and it's still hard for me to explain it. But basically what it's showing is a normal curve. Curve declines here. You're basically, the physics of the heart is declining. The stretch and the ability of the heart to deliver its blood decreases with an aging heart or failing heart. So what happens is in the mitochondria, you see this in a healthy heart, and then it starts getting a little bit more disorganized and even more disorganized. And the end stage is the muscles look a lot more disorganized. That's an unhealthy heart, maybe a heart that's had a heart attack, a heart that's got a lot of vascular disease. So we can see again, the heart is mainly a muscle. And so you look at sarcomeres, which are the striated muscle, which you look at the structure, and you can see it degenerating with a failing heart. But this is really interesting, and this goes back to the physics. And I showed you something here. I'm going to tie some things what I just showed you earlier. You look at the whole hematocrit, you look at the red blood cell, you look at plasma viscosity and other constituents. Look at viscosity. Viscosity is the thickness of the blood. If you have thin blood, you have thick blood. And there's different ways of looking at it, okay? And I'm going to probably be on thin ice here, okay? But I know in either Chinese or maybe Ayurvedic medicine, there are different ways of looking at blood throughout the season in different states here. But the way I look at it is, I look primarily at fibrinogen. I look at the thickness of blood. Thicker blood, more likely to clot. Well, what happens is, the easiest way to look at it, besides fibrinogen, is just looking at your hematocrit or red blood cells. Hematocrit used to be a measured amount. You would spin down the blood with a centrifuge, but nobody does that anymore. What you have now is just flow cytometers. The flow cytometers are now measuring the amount of red blood cells that are flying by, and then they infer the hematocrit, which is the number of the hematocrit. So most docs don't even know this, and I spent so much time doing QA in my lab that I know a lot of the inside information that the flow cytometers that they're using now. It turns out if your hematocrit is high, everybody worries about it. It's actually the number of red blood cells, because they get it to a certain number, they can clump, stick together. Now you got a problem with heart attack or stroke. So these viscosity figures are important because thickens the blood, the risk for heart attack or stroke. So I showed you earlier, this is a problem. Any bifurcation here, that's where this stuff is going to be a problem, because you've got these eddy currents here, and you've got areas of high shear strength and low shear strength. I always thought it should be the opposite, but the point is where you have low shear strength, that tends to be areas where you're more likely to have injury. Injury leads to inflammation. Inflammation leads to heart disease. So now what we have is well, here's just a pure mechanical model. Forget the lipids, forget the cholesterol, forget all the, maybe just from the sheer mechanical model. And there's one or two books that I've read. They're incredibly beautiful books, all physics, showing just from the shear forces, stress forces, and just the mechanics of blood flow alone, when you come to these bifurcations and you have these eddy currents, that alone there, over time, is an area where you're going to be more likely to have blockage of the artery at these bifurcations. The same thing with the bifurcation of the left main, the left anterior. All these areas where you have the bifurcations is a problem. Again, you can see these eddy currents right here, more likely to have blockages there. Again, showing you what happens, okay? So again, this shows here lower strength and high strength shear fractions here. This again, I don't know if this is going to work. This is really great. It's really great. Never works. And what it's showing you is, again, as we get older and older, that the shear forces are building up, and just the simple shear forces, it's sort of like, a bridge that's been around for 150 years. The shear forces and the stress forces begin to take their toll. I'm going to go through this kind of quickly, but this is something that I was really interested in a few years ago, and I wanted to get this machine, and looking at elasticity. And just the elasticity of another way of measuring arterial health is just simply how elastic are your arteries, okay? So you have this thing called elasticity, distensibility, and you look at pulse wave velocity, augmentation index, and stiffness index. So it gets pretty complicated, and you can shift these curves right here where you lose elasticity. So arterial stiffness is a major cause of heart attack, stroke, and myocardial ischemia. Again, Remember I told you glycation increases stiffness? It could be that these shear forces are increasing stiffness, but as we get older, everything's getting stiff. Muscles are getting stiff, our lens is getting stiff, arteries are getting stiff. So it's a major cause here. So this sphygma core was a way of looking at the pulse. So you look at this pulse wave here and right here, and you get these things called reflected waves, and then you look at these amplitude of these reflected waves, and you come out with an augmentation index. And basically, you're looking for the difference between the radial artery and the aorta, because the aorta really is where a lot of disease starts. And again, this was a great video. Boy, I really thought this was going to work. And this one, I did this one here. This one I did on myself. And I said, okay, I said, here's where I was, and here was I think this was the augmentation index, and I went here and I said, oh, that's cool. I think I was about 55 or 60 when I did this. I might have been 60 when I did this. So I thought, well, 60 down to 40, that's good. So it's a different way of saying, oh, again, back to what Sydenham said, you are as old as your arteries. So it's more pliant arteries, less stiff arteries, better health. Inflammation and stiffness, so it's a chronic inflammation associated with endothelial dysfunction. Inflammation may stiffen the arteries. That's where we come into arginine, nitric oxide, endothelium, CRP. Again, we've talked about this, it's associated with brachial artery pressure, pulse wave. It's an inflammatory marker. Arterial stiffness is an important factor. This is where, see, here's where I look at CRP is not really related to infection, and I look at small artery stiffness. So let's talk about this inflammation or this evolution here. So this is a perspective in the 1990s. Inflammatory proliferative process insult to the endothelium, smooth muscle, large number of growth factors, cytokines, vasoregulatory molecules participate in this process. So what happens is you have these correlate between here's a thin cap and here's large lipid, and you have these other factors. You put a correlate, and here's what happens when you start getting this filled up. And here's a progression of an artery that's getting more ischemic, more cerebrovascular disease, peripheral vascular disease. It's a progression of this. But I'm going to skip ahead here because what's happening is you got this endothelium, smooth muscle, inflammatory cells. So I kind of alluded to this earlier. What are those cells that are floating around? There's macrophages, lymphocytes, and mast cells. So what's happening is these monocytes and lymphocytes are found in the atheroma. They're expressed by the endothelium, expressed by the microvessels. This is what's going on. Now this kind of leads into what Christine Green was saying. Is it chlamydia? Is it some other factors? But the end process is you got all these smooth muscle cells. You're going to have these migrating cells that are in here. So it's the inflammatory things going. So this is vascular adhesion molecules. You've got another molecules here. And you've got these macrophages in here. All these inflammatory cells are trying to reduce inflammation, but they're actually making it worse. And as they get worse, you get this whole cascade here of LDL, HDL, and you get all these things, chemotaxis. So it looks like a complicated thing, but basically it's LDL being oxidized. All these other factors are coming in, and the system goes awry. It just spins out of control. But the point of this is this. LDL and cholesterol did not start or cause this process. LDL is recruited in this process initially to repair the process. But eventually it comes in here, and the LDL starts getting oxidized, and you start getting all this stuff here, all this inflammation here, all this oxidation, LDL oxidized by all these macrophages, histiocytes, and eventually this thing pops open, this pops out here, blood pops out, platelets come together, stroke or heart attack. Inflammatory process. LDL didn't cause it. Gets recruited in the process. One of my friends who was a really great lecturer said many years ago, cholesterol, found at the scene of the crime, not guilty. So let's move ahead. We've got quite a few more slides here. Calcium paradox. I love this. As we get older, what's happening is, I try to tell my grandkids, I tell my younger patients, when you're younger, you're banking calcium. You want that calcium going to your bones. You want to get as much calcium because you're banking it. And you want that to go in your bones. What's happening is we get older, for one reason or another, we have low calcium. And you believe in the hypothesis that I don't believe in, which is we should restrict our calcium, really don't take any calcium, because when you restrict your calcium down to nothing, I'm not going to get any extra calcium, body says, fine, I'll just steal it from the bones. And what happens is we get this reverse calcium flow, where calcium is now being recruited out of the bones. So when you're younger, calcium is going into the bones, okay? And as we get older, calcium is coming out of the bones, because we say, fine, we're going to bank that calcium, but we need it. We need it for muscles, we need it for cardiovascular tone, we need the calcium, we don't have enough going on here. And there's other factors. Not enough vitamin D, not enough vitamin K. Vitamin K. Another point, I want you to remember this, vitamin K. Because what's going on here is parathyroid hormone starts to get turning on. So what happens is, the body senses for some reason or other there's not enough calcium. Parathyroids, which are here, turn on, they start taking calcium from the bones. Parathyroids functionally start resorbing calcium from the bones. That calcium then goes right into your coronary arteries and into your valves, which nobody's looking at. Valves in your coronary arteries. So this is a very complicated thing here. Calcium is really essential. There's this vascular process here. This is a normal aortic valve. This is a diseased aortic valve. It's calcified. So even when I see on an echocardiogram it says a little bit of calcium, don't worry about it. Always bothers me. Because a little calcium always ends up being more calcium, and eventually that valve becomes a disease valve.
Picked up on an imatron?
This is, no, because they're looking at the blood vessels. It could be, but this is one you will pick up on an echocardiogram, but not the imatron. So that's a diseased artery, or disease valve. That artery is probably headed for replacement. You don't want that. So what do we do? Here's a central dilemma. It's a calcium dilemma. So interestingly, here's an inverse correlation between osteoporosis and aortic calcification. Osteoporosis, calcium in the matrix is decreasing. It's going into your arteries and going into your valves. And incidentally, Coumadin greatly enhances that bad process. So here's calcifications, here's osteoporosis, here's hip fractures, vertebral fractures and hip fractures. You can see they're correlated. So here's aortic calcification, osteoporosis, they're going up. Calcium coming out of the bones, osteoporosis, calcium going into the arteries. This is kind of an interesting thing. I tried to make this correlation between a bone with arterial flow and an artery, and I couldn't quite make it, but they're very similar in terms of how the bone is perfused, how the bone's laid down, and how basically what's happening with our arteries, they're becoming ossified, almost like petrified. That's what's happening with our arteries. They're being petrified as if they're now becoming bone-like. How do we prevent that? So how do we prevent that? Vitamin D. Now I got the story of vitamin D here. I got that from Bill Grant, and I kind of picked up, and Bill Grant was really the guy Rick kept talking about vitamin D, showing all the epidemiologic studies. Vitamin D is critical. And I put virtually every one of my patients on 5,000. I have a lot who need 10,000. I've seen some who need 15. I have even some patients who need 20. I think the 20 means that somehow they're not absorbing fat-soluble vitamins, but it's not uncommon to see people need 15 or even 20,000. But everybody goes on 5,000. Occasionally, some rare instances, tiny little women that get by with 3,000. But 1,000 will not do it. You need at least 5,000. But it's got to be with vitamin K. So vitamin D goes, you can get it through sunlight, but you'll never get enough by sunlight. If you go to Hawaii, you go to the Caribbean, you lay out in the sun, you will get enough vitamin D. We don't live in the Caribbean. You won't get enough. And I remember many years ago, it was Claire, who was it, Claire? There was a lady who used to come from Berkeley. Yeah, Claire Felix. She used to come from Berkeley, and she was in a set at this latitude, 37 to 38 degrees. You cannot get enough solar insolation to raise your vitamin D. So you got to take it internally, and you got to activate it, okay? So vitamin D receptor binds here. Affinity is such and such. But it has numerous effects on bones. It's a transport and regulator of bone matrix, provides proper balance of calcium, potent effects on growth differentiation. But it does more. Vitamin D, whenever I get a cold, I take 50,000 units of vitamin D for 5 days. I personally think that vitamin D, in my experience, vitamin D is actually way more potent than vitamin C. So vitamin D actually is a hormone and has all these other properties. So you look at, here's the vitamin D receptor. So let me talk about vitamin K, because they work together. And you got to do them together. So vitamin K, you have this vitamin K1, vitamin K2, and here's vitamin K2. So here's what they call the MK4, has 4 tails. So this menoquinone, so there's 4 tails here. So it's a big, long, lipophilic molecule. And then you have the vitamin K2, that's the MK7. Now, Ralph Halsworth talked to us about 8 years ago, and he was one of the guys who was really promoting MK7. And now you'll see MK7, and that's the big thing. You got to get MK7, that's way more powerful than MK4. I don't believe it. No one's ever shown me any studies. The MK7 that everybody's taking, if you look at what you're getting 40 to 60 micrograms. I want people to have 15,000 micrograms. There's no way you're going to compare 40 micrograms with 15,000 micrograms. So the MK7 story is one that I've never bought into. I want people having a lot of this. Vitamin K2 and vitamin D are essential for bone health and arterial health. Why? Because it goes beyond that. Vitamin K goes to gamma carboxylation. Then it goes to the GLA matrix protein. GLA matrix protein. You need vitamin K for GLA matrix protein. GLA matrix protein reverses calcification. GLA matrix protein is vitamin K dependent. It's what prevents calcification or reverses calcification.
So you got backwards. It's matrix clot protein, MGP.
Well, they're related. Okay? So here's the MGP. Okay? So the MGP right here is what's inhibiting vascular calcification. And that's the point. The point of this is it's the vitamin K that is making this active, and that is what's preventing vascular calcifications. So vitamin K is a really important one. Population has found that high dietary vitamin K2 intake reduced aortic calcification, risk of myocardial infarction, cardiovascular disease by 50%. The effect of K1 was less evident, and there were some randomized studies showing high intake of vitamin K completely blocked the process of our age-related arterial stiffening. I wanted to really make this point about vitamin K. GLA protein, matrix GLA, and osteocalcin. They're all related, vitamin K dependent. Let's talk about anticoagulants. No, I don't want you to look at that. No, we got to move ahead, okay? You're not going to get that. I want you to just get the basic concepts here. So this is what causes clots here. Here's platelets, okay? And here's fibrinogen, causes fibrin, and it causes clots. You have two systems. You have the intrinsic system, the extrinsic system. Intrinsic system is all this stuff here. The extrinsic system is platelets. Platelet is what causes an initial clot. Cut your hand, platelets adhere, stops the bleeding. The intrinsic system is this long cascade that comes down to fibrinogen and long-term stops the clot. Why is this important? Because you can take nutrients that affect every one of these without ever touching Coumadin. So here's nattokinase. This is a fairly complicated thing, but basically I still look at nattokinase, which comes from the natto bean, which is kind of awful tasting stuff. I put most of my patients on nattokinase. I take it every day, morning and night without fail, because nattokinase will reduce fibrinogen levels or prevent fibrinogen becoming a problem. Fibrinogen, inflammatory factor, thickens the blood, causes clots, heart attacks, and strokes. Nattokinase, very easy nutritional way of reducing fibrinogen deaths, risks. So here's a conventional answer. This is a conventional answer. And when I wrote this newsletter that you should have read, even I had this moment because I wanted to work through this, and it took me a few days, and I finally kind of looked at all the studies, and I came to this aha moment like, I can't believe I never saw this just in one thing. So here's statins. So the idea is that you have this cholesterol synthesis, and it goes through these various stages, and it goes through farnesyl, squalene, and eventually comes into cholesterol. So here's the statins. Problem is, the statins work too high on the chart here. So here's your acetyl-CoA, here's HMG-CoA, here's mevalonate. See, here's cholesterol. Okay. So the HMG, which are statins, go high in the cascade. A bunch of other stuff happens in between there. So here's the biphosphonates, terrible for you. Here's steroid hormones. See that? So I used to say facetiously, you need a lot of cholesterol for your sex hormones. Well, it's actually true. And I've never been able to actually prove this, but I know as we get older, one of the reasons I think our cholesterol rises is because our testosterone and our estrogen levels and all our sex hormones are dropping. Whether that's true or not, I haven't been able to nail that down. But there's no question that cholesterol is the basis of vitamin D, bile acids, sex hormones, and modified proteins. So what happens is, if you go back and you block it, all these steps are getting cut out. Plus CoQ10, vitamins A, E, and K, lipid-anchored proteins. High up in the cat, all this stuff is being short-circuited. And I did look this up. Someone told me about this. I looked up that, I think it was Merck, that took out a patent in about 1992. Right. 1992. CoQ10 and a statin. 1992. They even knew then. And they, for some reason, decided, well, there's no money in it, or not going to candidate. Somehow they just put it on the shelf. They said, well, we got the patent. Okay? But they knew even then that statins were going to do bad stuff to your CoQ10. So any of you who are still on a statin for any reason, you got to be taking a lot of CoQ10. So these are all the problems right here, okay? And here's that patent. Actually, it was 1990. I thought it was 1992. So here's the patent. So I actually looked it up, because I never trust anything people tell me. I look it up. I said, there's a patent. Fine, let me look it up. So I looked it up, and there it is. It's very clear. I got this right off of the U.S. Patent Office. There it is. A pharmaceutical composition and method of counteracting HMG coactase reductase inhibitor-associated myopathy. Whoa, you mean they knew about this in 1990? And they still say, they said, well, this only happens to a few people. Only a few people. Well, guess what? Maybe I see all those people, because I see people who are wrecked on statins. It's not everybody, but enough of them where it's not a minor thing. It's a big deal. I also see people whose memory goes out and other factors. So what are the statins? Crestor, Lipitor, Mevacor, Pravachol. Then let's look at anticoagulants. Coumadin, heparin, Xarelto, Pradaxa. They keep proliferating. Aspirin, Plavix, Tyclid, Persantin. These are conventional approaches to anticoagulation.
What's the total revenue for those drugs?
Gazillions. Actually, probably in the hundreds of billions. I mean, I'm just guessing, okay? But it's probably in the 50 to hundreds of billions, okay? So Coumadin is the one, actually, they're starting to phase this out because, now we could probably make more money on Xarelto and Pradaxa, so why don't we go to those? I'm telling you, I've seen this over and over again. Coumadin risk-benefit ratio is too high. The risk of accelerating coronary atherosclerosis, valvular calcification, bleeds, hemorrhages is way higher than the benefit. I had this one lady came to me, she's 85 years old, pretty spry lady, and she had atrial fibrillation, she was on Coumadin, and I talked to her, and her husband and her son was there, and I said, okay, here's a routine that you can go on. And I gave her my routine, and I'll show you in a second. I said, here's a routine. You don't have to be on Coumadin, but I don't want you to do this. I'm just showing this is what could be done, because you can't do this if you don't feel comfortable doing it. Okay, so 2 weeks later, I get an email, she stroked, thinking, oh man, I blew it. Turned out she had never stopped her Coumadin. So even on the Coumadin, she still had a stroke. The Coumadin didn't prevent the stroke, and meanwhile, I've seen lots of people over the last 15 to 20 years. I know it's accelerating atherosclerosis, cardiovascular disease, and valvular calcification. So these are the traditional approaches. HDL trumps LDL. Know that HDL, there was this drug here that was developed by Pfizer, and it was supposed to raise your HDL, but stupidly what they did is, and every science student should know this, They didn't do the experiment where they did just this. No, they did it with Lipitor and this. So it wasn't a pure experiment. They said, well, it didn't work. You never tested the drug. You tested the combination. They said, well, we'll give them a double whammy, and it didn't work. So here's the HDL protects. Here's HDL protects. HDL protects. Here's the reverse process. HDL is reverse flow. It's taking cholesterol away from the heart. That's why high HDL is really protective. So if you have an HDL of 70, 80, 90, 100, really protective. I see some guys are HDL. I've seen some guys with HDLs in the 20s even go down to 12. It's really hard. And that one individual, we gave him a lot of coconut oil. That actually did work for him. Niacin works in some cases. So this is something I want to get across. What is the percentage decrease from this to this? What is that percentage decrease? What is it? Right? 50%, right? What did you say?
2x.
It's 2%.
No, 2x.
It's 2%.
Oh, yeah, okay, right.
It's 2%.
You're right.
It's 2%.
You're right.
Okay? When you go from 4% to 2%, it's 2%. If I'm trying to sell a drug, if I'm trying to sell Tide, if I'm trying to sell any product, I'm going to tell you that's a 50% reduction. And you're going to say, this is a great drug. 50% reduction. It's a 2% reduction. You got to understand this concept because nobody gets it. And even the New England Journal came out about 5 or 10 years ago and they say, you got to stop with this relative percentage change and go to absolute. And nobody will do it because you're not going to sell any drugs this way. So here's the deal. How about if I show it to you this way? Can you see the difference there? Okay? All I did is I changed the scale. Here it's 5%. I just changed the scale. Can you see the difference there? No, because now you can actually see there's hardly any difference there. I just changed the scale. That's all I did. So I want to sell this product, great. If I don't want to sell a product, I'm going to show you this one. This is point number 3 I want you to take away. Relative versus absolute statistics. Okay? So here's the deal. Here's why I'm telling you this. So I looked at all the statin studies. Okay, these are all the major ones. I've gone to a number of lectures. I was trained in starting a regional lipid disorder center by Robert Saperco. So we went to a number of lectures. He's like one of the best. He founded Berkeley Heart Lab. Great guy. Went through all these studies. And what you come out with is, here's all the major coronary artery events. This is what you'll hear. 43% reduction, 67% reduction, 54% reduction. So the average of all these studies here was 30%. Wrong. It was 1%. It's just simple math. It's just simple math. You'll never see this here. All I did was I just took these numbers here and I just did the math on it. Here are the relative percentage. I said, see, it's 30% reduction. This is a great drug. No, it's 1%. Okay? Cancer, 5% reduction. No, it's nothing. All-cause mortality, 11% reduction. Here was 28% reduction, 30%, 40% reduction. No, it was 0.5. It was no change. In every one of these categories, coronary artery events, cancer, all-cause mortality, statins had no effect. None. No beneficial effect. No beneficial effect. So here's the thing. Here's where I have to qualify it. It doesn't necessarily mean that any individual, one individual in this audience here, maybe it will help you. And my estimate has been, because I don't think anybody's really done this, my estimate is if I took everybody with elevated cholesterol, maybe about 20% of you, it might have some beneficial effect. And the other 80%, it's either going to cause you problems or going to have no effect whatsoever. 20%. Then you go to this thing called intention to treat. How many people do I have to treat? How many thousands and millions of people do I have to treat to get the desired effect? But if you look at population, no effect. If you look at individuals, maybe there's an effect. Pretty astounding when I looked at this. So let's look at the endothelial rejuvenation. We look at arginine, nitric oxide. So there was a lot of think about arginine. I like certain products that increase nitric oxide. So what is our goal? Goal is to arterial reconditioning, rejuvenate, revitalize, re-energize, optimize. Nutrients, orthomolecular approach as much as possible. Nutrients. I prescribe statins Probably never. I'll write the prescription, but to actually initiate it, the only time I'll ever write if the patient says, I'm really nervous about my cholesterol. Okay, fine. If you're really nervous, fine. I'll give you a statin, okay? I'll give you a little statin. But I hardly ever initiate a statin. I'll write if someone wants it, and I'll tell them, let's start with low dose, and we'll modify that, okay? So let's look at this. High-dose fish oils, and again, none of you are taking enough. You're all taking caps. You'll never get enough fish oil with caps. You will never get enough fish oil with caps. You're counting caps, you'll never get it. Because you count it up, I want my patients to get 5,000 EPA, 4,000 of DHA. That's 10 grams of fish oil. But it's the EPA and DHA I want my patients. I want 800 to 1,200 vitamin E, high dose. Probably protecting the brain, vitamin C, a lot of vitamin C, and vitamin K, 15 milligrams. That's basic. And I do that in every patient. I don't know that I achieve that, but that's the goal in every patient. High-dose fish oils, rheology. Red blood cells will not aggregate with high-dose fish oils. How do we know this? Every time you go for surgery today, your surgeons have now gotten smart enough to say, incidentally, before you do the surgery, stop your vitamin E, stop your fish oils, stop your aspirin, stop your NSAIDs. They've gotten smart enough to know this does thin your blood. Surgeons know this. Internists don't. Surgeons see, internists think. So this is a basic approach. Then I look at alpha lipoic acid. Is a really important triple action antioxidant. CoQ10, I try to take 200 to 400 milligrams a day. I used to think that was a high dose. When I treat cancer, I treat this with 1,000. So to me, 200 to 400 is kind of an average dose. Mitochondrial function needs CoQ10. Estradiol is really important for arteries. It really increases vascular tone. It keeps you younger. It turns out that estradiol is important for men as well as women for bones. Testosterone, really important for health. Taurine. Taurine I'm starting to play with a lot more. Taurine is really good for your eyes. It's good for your arteries. Calms you down. It's great for your heart. Carnitine. I use big doses of carnitine. I can't get most of my patients to take enough carnitine. I take 3 to 6 grams a day. It's a big dose. Carnitine comes from the Latin word carne, meat. That's where you get carne. So people who are not getting enough meat will not get enough carnitine. Carnitine is essential for cardiac muscle function. Carnitine is really essential. And nobody's getting enough of it. I do ribose, 2 to 8 grams. Ribose is a precursor to ATP. It's a substrate for ATP. So all of these, and then benfotiamine, I'm really big on that. It's another activated form of B1, thiamine, which is really important. So this is sort of my large list here. If you're taking all of these, you're in really good shape. Niacin, methylfolate, B12, B6, and Neo40. Neo40 is a different way of getting arginine. It increases your nitric oxide, really heart healthy. Niacin, methylfolate, and it's a 5-methyl because all of us probably have the MTFHR gene, so it's not folic acid. And incidentally, Steve will know this, and I knew this even when I was studying biochemistry. There's no such thing as folic acid. There's the family of folates. There's the 5,10-methylene folate, there's the 5-methylfolate, and there's 3 different pathways. And quite frankly, as good as I am, when I look at folate, I've never been able to master it. And even the people who I know, some of my buddies who claim to master it, no one has ever explained this pathway clearly. It's very complex. So simply put, 5-methylfolate. I use Folapro. I use a lot of vitamin B12, a little bit of vitamin B6, folate, and Neo40. Nattokinase, 100 milligrams twice daily, morning and night. Fibrinogen, prevents heart attacks and strokes. I take this routinely, morning and night. I'm bummed out when I hear physicians now having strokes and cancer and so forth. Physicians used to be really healthy. Heart-friendly exercises, resistant and aerobic, high protein, low carbohydrate. I'm really into the paleo diet, low carbohydrate, high protein, no smoking, alcohol. We talked about this at dinner. I'm hammering on people. Some people get it, some people dispute me. Alcohol. Steve is the one who said alcohol is a carcinogen. Didn't you say that? Alcohol is a carcinogen. Now I know you think, okay, alcohol, whatever. My theory is this, and nobody can do this, is if I were to buy into alcohol being really healthy, is you had half of a small glass a night, I'll buy into that. Stimulates the gastric juices, settles you down a little bit, probably not harmful. 2 glasses a night, not healthy, okay? And we talked about that at dinner, not healthy. Stress reduction, meditation, yoga, love, dental hygiene, teeth are a big source of bacteria. I never believed this, but that's why, when your dentist says, oh, you got mitral valve prolapse, we're going to give you some antibiotics. Direct connection between your teeth and your heart. Avoid chlorine and chloramines. I have a filter on my shower. I get all the chlorines. It's either chlorine or chloramines. We're being poisoned by chlorine. You'll actually get more chlorine by your shower than you will by drinking water. I was nervous when I went to dinner tonight. They gave me tap water. I never drink tap water. The water in this valley, in this whole Bay Area, is poison. It's killing cats. It's killing everybody. It's poison. This chloramine and chlorine is bad stuff. My father-in-law worked in a chlorine factory. Now, this is a little, I could say this is a little exaggerated, but he worked in a chlorine factory. In those days, like when I was in ER, when he worked in the chlorine factory, kind of macho, we didn't have masks or anything, died of lung disease. Chlorine's a terrible, terrible thing. And there's ways of getting around it. So I filter out all the chlorine, and I never drink tap water. Friends and lovers, social bonding. It was Dean Ornish that said that actually the biggest risk factor for heart disease is disconnectedness, lack of connections. And I worry about this in younger people today because all I see everybody walking down the street like this. And I see couples walking down the street like that. I hear now, teenagers now, they're doing this at home, at parties. They're not even talking to each other. They're going to leave, they'll talk to each other like that. Disconnectedness. Is Facebook making us more connected or more disconnected? We're nearing the end. So look at this here. This is my routine, okay? High-dose fish oils, turmeric, vitamin E, ginkgo biloba, nattokinase, clean water. This is my substitute for Coumadin, for all the anticoagulants, to keep your heart from clotting. You have atrial fibrillation, this is what I recommend. High-dose fish oils will prevent red blood cells from aggregating. The turmeric, fibrinogen. The vitamin E, aggregation. The ginkgo biloba is just as powerful as aspirin and all the other drugs that are being given today for antiplatelet drugs. Nattokinase, again, fibrinogen and clean water, I told you, is really important. You need to be hydrated. When I used to work with Whitaker in the 90s, his stock answer, every time if someone asked him a question, he'd say, you need to drink more water. And someone asked him another question, he'd say, you need to drink more water. And so what happened, if you're sitting in an audience and everybody leaving, they'd be going to the bathroom, they'd be leaving, because everybody was drinking more water, and they all say, good, they're flushing their kidneys out. Water is an active metabolite. Water is not a passive thing. It's for your discs. It's for your heart. It's for your brain. Your brain's mainly water. We need more water. Even I don't drink enough water. It's got to be clean water. So here's vitamin C in the heart. This also was a great presentation. I have to skip over that one. Okay. This is Sourcing 9. This was something that was sort of a knockoff of Linus Pauling. It was a way of preventing the Lp(a) from becoming a problem. At this point, I was going to say intermission. I was going to put some slides up here of some of my own photographs, just to make sure you guys were still awake, because we're nearing toward the end here. The Sourcing 9 is pretty good stuff. So Lp(a), another way of looking at cardiovascular health, this is a really good formula. Vitamin A, which I don't like, riboflavin, pyridoxine, vitamin E, folic acid. So these were not real high concentrations, but I really like the carnitine, I really like the taurine, the arginine, the proline, and the ascorbic acid. So we can get this individually. So here's a Sourcing 9. Here's the omega-3 studies showing the HDL and LDL, adhesion molecules, why fish oils really help with adhesion molecules. And I want to go back one thing here, as you're getting toward the end. Every 6 months, you're going to hear a new oil. It was, okay, I'm almost done. So it's flax oil. Then it was salmon oil. Then it was krill oil. And then it was clary sage seed oil. Now it's, it's got to be New England green lip mussel oil. And now, actually, it's omega-7 oil. No, it's got to be this other oil. Now it's the omega-7 oil because Peskin says we're doing it all wrong. So every 6 months, you're going to hit something different. I'm still sticking with pure fish oils, not cod liver oil, pure fish oils, 10 grams a day. So the fish oils are still really important. Greatest risk factor is disconnectedness. Best ways to reduce stress is love. I got that from David Zava, who talked here once, and I said to David, what's the best way of reducing all the cortisol? And he said, love. I said, no, biochemically, love. And again, will you still love me? Will you still care when I'm 64? When I was 25, it seemed a long way away. It's not now. Hungry heart, everybody needs a place to rest. Everybody wants to have a home. Don't make no difference what nobody says. Ain't nobody like to be alone. Bruce Springsteen. And with that, I thank you for staying awake and listening. There's some books you can read. These books here, 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 and then read my book, and then go off into the wilderness. Thank you again.